All right, thank you guys for joining in. I'm Cliff Dupre with the Salute America team here at UT Health San Antonio. I'd like to welcome you to the next webinar in our series called Let's Improve Health in South Texas and Beyond. Today's webinar is The Thing That Could Save Your Life. Our moderator is Dr. Amelie G. Ramirez. Dr. Ramirez is director of the team here at Salute America and its home base, the Institute for Health Promotion Research at UT Health San Antonio. She spent over 30 years directing research on human and organizational communication to reduce chronic disease and cancer health disparities affecting Latino population. She's also Associate Director of Cancer Outreach and Engagement at the NCI-designated Mays Cancer Center at UT Health San Antonio. Dr. Ramirez?
Thank you very much, Cliff, and thank you to all our audience today. We are delighted to come to you to share information about what you can do to protect yourself and to reduce your risk for cancer. We find that cancer is one of the top two causes of death among our Latino population, along with cardiovascular disease. And Latinos also suffer more from certain types of cancers, mainly because of the late stage diagnosis. So this year alone, there will be, according to the American Cancer Society's recent report on Latinos and cancer, a little under 200,000 individuals will be, new cases will be identified, and 50,000 Latinos will actually be dying from this disease. So there's so much that we can do to live longer and to live healthier. And today, we are so fortunate to just have a wonderful panel that is going to help us look at these topic areas and talk about what we can do to help one another. On our panel today will be Dr. Jessica Trevino Jones, who is a breast medical oncologist and associate professor in the Division of Hematology Oncology at UT Health San Antonio, and Dr. Marcela Mazo Canola, who is also an assistant professor for the Mays Cancer Center at UT Health San Antonio and also an oncologist, and Brittany Millard, who is a breast cancer survivor. So we all have an opportunity to hear from all of these wonderful speakers. But our first speaker really represents our webinar sponsor, Genentech, which is a biotechnology company and a member of the Roche Group. We are so delighted and pleased to have with us today Dr. Michelle Da Silva from New York City, who represents Genentech. Michelle partners with leading academic health centers and leverages her expertise in oncology and hematology. And also she's here today to share with us a very special campaign that's called the Love Letters campaign that was designed to reach out to Black and Latina women. So, Michelle, thank you so much for being here with us today. Can you share with us your thoughts on the importance of screening and also why this campaign was so unique?
Absolutely. Thank you for the opportunity to be here. As Dr. Rodriguez mentioned, my name is Michelle Da Silva, and I reside in New York City. I do work for Genentech, which is a biotechnology company. For those of you who don't know, we bring novel therapies to market, really to help individuals who are facing life-threatening diseases or serious diseases to really help change some of that trajectory. And I've been with Genentech almost 19 years. According to, some of the stats that Dr. Rodriguez just mentioned, 1 in 3 Black and Latino women will have cancer in their lifetime. And it's truly an unmet need in these different communities. Genentech has had a long history of not only looking at early treatment and intervention and diagnosis, but also a specific focus around women's health. And in response to some of the highlights that happened during the pandemic, we also saw a significant impact in our communities here locally in New York City. And that's where we identified this gap. I worked with my marketer, Allison Wimbush, to help me identify a campaign that we could bring to the marketplace to really activate these communities. And it's called Love Letters. And it's really focused on the female demographic. So our Black and Latina patients are really meant to, let me pull up the screen really quickly, just so you can see what I'm speaking about. Perfect. And so this campaign is unique, and I'll share with you why it's so unique. is it was developed for the community by the community. And I think that's the most important thing that we learned in the creation of this campaign. In addition to that, was working with our local health systems, working with our local advocacy groups, and also in partnership with the American Cancer Society. But really, the intent around this is these are real stories of real women. So it is created by the community for the community. But the artistry work that you're going to see here too is also depicted from Black and Latina artists. Using portraits of women that either lost their lives to cancer or survived. And these stories were meant to make a meaningful connection to change that trajectory. And you can see that these letters here, they're both in English and in Spanish. And we're proud to say that we have some long-term metrics now looking at like, not only did this activate this community, about 80% of our Black and Latina patients, but they were also inspired to take action and also inspire to work with their loved ones about their own health care. In addition to that, we've launched here locally in New York City, but it's now being spanned across the United States. It's also being used in our Latin American countries as well, and even in some parts of Africa too, just to really help, again, change some of this trajectory. Some of the things that we really learned in activating these communities is the importance of working with the community, working with our health systems, and we wouldn't be able to bring this campaign to life and to market to really change the dynamics that we currently see in this space without the work of the community and the people that are really going to make that change locally. And with that, I will turn it back over to Dr. Rodriguez to be able to share more around it.
Thank you so much, Michelle. This is an exciting campaign, and I know you all have got some wonderful results as well. So thank you for sharing, and we hope to learn more about it and how it can be utilized in other Latino communities. So, Dr. Jones, thank you for being here with us today as well. And can you describe the cancer burden of Latinos and how cancer screening truly plays a critical role in addressing that burden?
Thank you for having me here today, Dr. Ramirez, and to everyone on the call. It's an honor to be able to share this with you. And cancer doesn't have to be a scary word, even though, just as Dr. Ramirez had shared, that cancer is the leading cause of death in our Latino and Latina populations. And for some reason, we're still investigating why, but cancer is higher for Latina women, and often our cancer is more aggressive than that for Caucasian women. Now, cancer doesn't have to be a bad word. We can find it at its early, most curable stages. And when a woman gets regular cancer screening, that is to say, when she starts her mammograms and if she does them regularly, oftentimes we can find cancer before you feel a lump. And that makes all the difference because if we find cancer early, we're more likely to cure it. Now, we don't have to let being a Latina be any reason for us to have anything less than the best. And so for that, I would say, even though cancer is on the rise, if we watch with our screenings, we can still have a better outcome.
Thank you so much, Dr. Jones. That is so important to hear. And like you said, we don't have to fear the word cancer. And that is just so true in our Latino community that, you know, people sometimes don't want to talk about that they've had cancer or if there's been cancer in their family because they just fear the word saying it. So we need to change that perspective. We need to change. Please come in early so we can help you. So with that, Dr. Canola, you've been doing a lot of cancer screening, and that goes hand in hand with cancer prevention. And you see a lot of breast cancer patients. Tell us about what you're seeing and how you encourage your population to try to come in early.
Dr. Ramirez, and to my co-panelists, thank you so much for the invitation. It's an honor for me to be here. So I would like to touch on some points that I feel are important, and these are the points that I highlight with my patients when I see them in clinic, or even when we have the opportunity to interact with the community. So it's important to understand that early detection saves lives. So we know that when we diagnose a cancer at an earlier stage, the chances of curing that cancer and having a successful outcome are significantly higher. It is also important to do this, what we call personalized screening. I will share that in a meeting that we were having a moment ago. We have some guidelines in the literature as far as when to do cancer screening. And I'm referring specifically to breast cancer, colon cancer, cervical cancer, and lung cancer. And the truth of the matter is that we have some general guidelines, but by you approaching your doctor, talking to your doctor, and even with the services that we offer in the cancer center, we're able to identify if you perhaps have a higher risk of having cancer in your lifetime. So it's important to have those discussions as far as what's your family history. Maybe you need genetic testing to further stratify what you're going to need for your screening and know if perhaps you should be screened differently than when we screen in the general population. Or things to keep in mind, lifestyle is important. Certain changes in your lifestyle are going to be important to mitigate or decrease the risk of cancer. So you don't even have to, or decrease I guess, your level of worry. So exercise is key. I cannot emphasize that enough. We have data that shows that patients that are physically active have a decreased risk of cancer. Same applies for our survivors. When they're active, they exercise, the chances of recurrence can decrease as well. Healthy diet is just as important. I will also emphasize to our listeners today that alcohol consumption has been linked with increased risk of cancer, and that's something that we can do to mitigate or decrease risk. And also vaccinations. I guess nowadays vaccinations are a hot topic for multiple reasons that are not pertinent for our conversation today. But some cancers can be prevented through the use of vaccines. I will specifically refer to the HPV vaccine and the hepatitis B vaccine. So these two viruses and diseases have been linked with cancer. So accessing vaccination can decrease your risk of having a future cancer that is related to infection. Smoking, of course, we all know that that's a risk factor for cancer. It's important to try to stay away from tobacco products. And also in the community, for people that work, let's say, in construction or exposed to the sun every day, using your sunscreen to decrease your risk of melanoma so you don't get skin cancer, or using the equipment that you're assigned to prevent you to getting fumes of certain chemicals. Those are little things that you can do yourselves to mitigate or decrease your risk of cancer. But most importantly, I think education is key in the sense that sometimes we're afraid to go to the doctor. And it's important that we have these conversations with our physician, that we're persistent and we are, advocating for our own health to get the screening that we need. I know that I cover a lot of topics, but I feel all of those are important when it comes to the different strategies that we can use to mitigate and decrease and appropriately screen for these common cancers.
Thank you so much, Dr. Mazzo. It's so important. Yes, the list may be long, but it really takes our motivation to be aware and to talk about these issues, because sometimes we just don't do enough outreach and education to inform our communities. So thank you for that great reminder of the different things that we can do to reduce our risk. And now I'd like to turn to Brittany Millard. You're a young breast cancer survivor. Tell us what convinced you to come in for screening, and tell us a little bit about your journey.
Thank you for having me. It's an honor to be here and be able to share my story and maybe help someone in the community that needs it. So thank you once again for having me here. When I was 31 years old, I started developing a lot of pain in one of my breasts. The best way to describe it was a burning and shooting pain. And I brought it up to my OB at my annual screening, and she did a physical assessment of the area, and she wanted to refer me in for an ultrasound. At the ultrasound, they did find a mass, and I had a biopsy done of the mass and a lymph node, my sentinel lymph node as well. And I did later find out on September the 29th of 2023 that I did have cancer. At that time, I didn't know what stage I was at or too many details. And pain is not a common symptom according to a lot of research, but I would like to just emphasize that if something feels off with your body, it's important to bring it up with your doctor. And if it persists, then you should be just as persistent and, just making it known that, hey, something is really off here. Is there any screening? Is there any imaging? Is there anything that we can do to look at this area? I was very lucky to have a great OBGYN that did refer me in for that ultrasound. Unfortunately, I have heard a lot of really sad stories where women expressed that they were having pain, but because of their age being so young, they weren't referred into the appropriate imaging. And unfortunately, that allowed the cancer to continue to grow. In the beginning, in my particular situation, only having healthy Texas women insurance, it was very difficult for me to get in with an oncologist and receive coverage for ongoing treatment. So I really did have to advocate for myself a lot. I didn't find a lot of advocates or resource navigation in the community that were able to help me. But since then, I have become a lot more aware of a lot of resources. And just want to say that if you ever find yourself in that situation, not to feel discouraged, and that there are a lot of resources out there. There are a lot of advocates, a lot of organizations that can help you get coverage within your community and even through the state of Texas as well. I ended up getting Texas Medicaid for women with breast and cervical cancer. After I was diagnosed, I chose to have a double mastectomy, which I had the day before my 32nd birthday. I chose to go through 5 months of chemotherapy, which sounds really scary, but it actually was not nearly as bad as I thought it was going to be. There's a lot of scary stories online, but the doctors and nurses really do a great job to sort of tailor your dosage to your body weight and also provide a lot of other medications just to make sure that your risk of nausea and really bad side effects and fatigue and issues with eating and stuff are properly managed. So that was very helpful for me. Having a really great care team is important. You should feel comfortable with your doctors. Now I'm on Lynparza, which is a PARP inhibitor, and that's just to continue to decrease my risk of any recurrence, since I did find out I was triple negative. I also found out after being diagnosed that I have the BRCA2 genetic mutation, which is very rare, but it still affects a lot of people. And unfortunately, even though I had filled out plenty of assessments prior to doctor's appointments regarding my family history, I was never recommended genetic testing to see if I may carry a gene that can cause cancer. And had I known that I had the BRCA gene, I could have surgically prevented myself from ever getting breast cancer in the first place. So it's very important to know your family history. It's very important to ask your family questions about your family history when it comes to cancer and other diseases. And the genetic test, it's very easy. It's just a blood test, and you find out right away within a few weeks or so whether or not you're at risk. And there are certain things that you can actually do, including more frequent screening that can actually help prevent yourself from getting cancer in the first place, or at least catching it very early. And if you have children, genetic testing is especially important. Now that I am aware that I carry that gene, I know that my daughter is at a 50% risk of also carrying that gene. So when she turns 18, I can actually help her to get genetic testing to see if she's a carrier as well.
Wow, Brittany, you've just brought up a tremendous amount of points that all women should be aware of. But, our Latino population, both men and women, are known for not wanting to come in for screening. So I'd like to ask our panelists, give me your best thoughts of how to break some of those myths and misconceptions, and what terms or phrases have you found to really convince? Because even I've had difficult with my own family members to get, to get them to come in, and I'm going, but I do this every day. Why aren't you listening to me? But so I'd like to kind of just hear your perspectives, because Brittany, you went through a lot of things. You were young, you advocated for yourself, you now learned about the importance of genetic testing. All of these things are so important for others to realize that they have the power to ask for these things as well. So let me turn to Michelle, and then Jessica, and then Marcela. For each of you, kind of give me your point of view, please.
Yes, thank you so much. And such an honor to be here today. Brittany, your story really resonated with me, just kind of thinking about being an advocate for your own health care. And you know your body best. And if you know something's off with your body, go to the doctor, ask questions. Don't be afraid to ask what's going on. Write down the symptoms that you're feeling. If it doesn't feel normal to you, that's a check engine light for you to know that something's going on, and to have a really good conversation with your doctor about that. And then I love your comment around, if you do know your family history, make sure you bring the family history along and share that with your provider as well, because I also think that's really important. And the last thing I'll just comment about is, don't be afraid to ask questions. Don't be afraid to advocate for yourself. You're the most important thing. And if you're going to be taking care of your entire family, you got to be here too. And so I think that's really important. Sometimes we prioritize other people in our lives without prioritizing ourselves. And there's a lot of data that supports that the women are the center of the household, and you matter.
Very well said. Thank you so much, Michelle. Jessica.
Well said, Michelle. And Brittany, thank you for your story. What Brittany just shared, it is so important for us to know cancer is on the rise in younger and younger patients. And I don't mean to say it as a fear, to cause fear in anyone. Instead, what I want to share is we should look at this as a way to advocate for ourselves, just like Michelle and just like Brittany were saying. If we know our normal, then we know what isn't normal for us, and not taking no for an answer sometimes. Women are more likely, especially Latina women, are more likely to have their medical concerns dismissed. They are more likely to have their medical conditions explained as psychologic or in their head. If you know what's not normal for you, you can go get another opinion, and you can keep getting opinions until you feel confident that you are safe. And with that, I would say we are more than just mothers and daughters and sisters and friends. We ourselves, we hold all of these roles. That's why we should invest in ourselves. And when we do invest in ourselves, when we go to get our test, screening test, that means I don't have a symptom. I want to go and just see to make sure everything's okay. Even if it does show something that's not okay, it will be. We have ways to treat everything. And I know I want to find something in its early, most curable state. And I want that for you too. Thank you.
Oh, thank you so much, Jessica. Marcela.
I'll just share something that I think resonates with me and that I frequently, share with my patients. For example, when they're hesitant, for example, to know about genetic testing or to even get the test done, even if it's indicated, information is power. Information is power. So even, let's see if you're blessed enough to be presented with the opportunity to know your risk better, right? You are in an environment in which thankfully, your doctor is picking up that your risk seems to be higher and they're offering you the genetic test. I think taking the opportunity to do that genetic test and learn your own risk is going to give you the tools to decrease your risk of you having a cancer down the road. So I think it's something that I want to emphasize to all our audience, because I frequently see the fear, and I tend to see it more in my Latino community. They're like, oh, I don't want to know. I just don't want to deal with the diagnosis. And if we know ahead of time that there is an increased risk for you, we're more likely to develop a strategy that will mitigate your risk and hopefully prevent that cancer from happening. The other point that I will make, and as I, advocating for ourselves, I think people in the call that have been through these journeys, and us as treated oncologists, and breathing you with sharing your story, that is so powerful. I think it's important to advocate for us and to seek the answers if we're not happy with the answers that we're getting, which is the point that Michelle and Jessica have been making in their interventions. But I think that is just so important. There's not such a thing anymore as being too young to have cancer, and we need to advocate for ourselves. If something is not right, doesn't feel right, you need to keep pushing to get an answer. Because again, having that clarity and that information is power, and it could save your life.
Great. Very well said. Very well said. Thank you so much. And before I continue with questions, I really want to encourage the audience. If you have any questions, please feel free to put them in the chat. And if you do have one audience, Dr. Jorge Gomez from Texas A&M, he'd like to know that after treatment and successful response, how do you deal with micrometastasis? It's becoming a new problem. Jessica or Marcela?
I think that this is a great question, and we need to also define what is a micrometastases. So what I believe that Dr. Gomez is asking is that when we have a breast cancer and we do surgery, which women is it potentially still in the body? How do we know if everything is out of the body? We don't have the perfect science yet. But that is why some women will be offered chemotherapy either before or after their surgeries. Depending also on if her tumor has estrogen on it, she will also be offered different pill therapies that we call hormonal therapies to try to prevent the growth of these micrometastases, or that is to say, we don't want it to come back, even if it is potentially somewhere else in the body. Dr. Mazo Canola, do you have another comment for this?
I think you're hitting kind of the nail in the haystack. We do have the technology available, or it's under development. We have a test that, for example, in the space of hormone receptor positive breast cancer, meaning the cancer that uses our hormones to grow. We had some what we call genomic tests that basically involve checking the genes in the cancer cells to kind of get an idea of who will benefit from chemotherapy, because we can say that they have perhaps a higher risk of having micrometastatic disease, and we can implement certain strategies to mitigate that risk. To Jessica and Dr. Gomez's point, it's still a challenge because these assays are not perfect yet, but through research, and this will let me jump into my next point. Clinical trial participation is so important because this is the way that we answer these tough questions. And this is the way that we all learn and we make progress. So down the road, we have that perfect maybe assay or test that will be able to tell us who's having micrometastatic disease, meaning little cancer cells that we don't see on scans, that that we can attack them and kind of move the needle and even cure even more patients.
Awesome. Good, good. I'd like to get your thoughts also on a comment that Dr. Jones, you mentioned earlier in terms of we're seeing cancers at an earlier stage in our population, particularly among Latinos. Perhaps, again, Michelle, Jessica, and Marcela, and any thoughts or comments that you might have regarding that?
Michelle, I'll let you start because I feel like I could do this all day.
No. Please go ahead. Please go ahead.
We're noticing that cancer is on the rise, particularly more so in Latino women, and it is happening at younger ages. So all three of these may be happening for independent or perhaps overlapping reasons. One, there is a hereditary component to cancer for about maybe 15 to 20% of them. Now, when it comes to our Latino and Latina population, and I want to briefly shout out to Dr. Ramirez because this is her work and she's trying to move the needle on this. we are trying to better understand how this works in, or how our genetic links happen within our Latino communities. We don't know all the genes yet, but more importantly, the bigger group of breast cancer is what we call sporadic, or it occurs because of we don't know why. And that is where our cancer adjacent, or these other conditions that are very closely linked to cancer, are really important to talk about, such as obesity, not being at our ideal body weight, the use of alcohol, tobacco, and also using hormone therapies, which is a little bit complex. So I will just leave it as a big umbrella of hormonal therapies.
I agree with Dr. Jones. I think it's multifactorial. I think definitely in the Hispanic populations, I am convinced that there are some genetic mutations that we haven't, maybe completely understand yet, because us Latinos, we tend to participate less in clinical trials. So perhaps there are even some mutations that we don't know that cause cancer that are specific to the Latino ethnicity. The other factors are probably environmental. I think obesity is one that is huge, especially in the South Texas region. We have high rates of obesity. I will say also our lifestyle, more sedentarism, less exercise, more alcohol consumption. And I think they're all multifactorial and are feeding into this of, seeing more cancers in women that are younger than 50. And I will say that it's not just breast cancer. We tend to see the same in colorectal cancer. Men are perhaps less likely to undergo colon cancer screening. Now we know that the recommended age is age 45. So perhaps, that combination of factors is what feeds into this, that we're seeing with patients in their 30s, early 40s, being diagnosed with advanced stage of cancers in general.
Great. No, thank you so much. And thank you for your comments on clinical trials. We'll get to that in just a moment. I wanted to ask Brittany, what challenges did you face being diagnosed so early? Did you have any insurance issues or any things that you faced because you didn't kind of follow, the preventative guidelines in terms of, women beginning at 40 or older to be screened? Were there any challenges there that you'd like to share?
Yes, there definitely were some challenges. At the time, I only had Healthy Texas Women, which I didn't know at the time covered breast and cervical cancer screening. So that's very important to know if you qualify for Healthy Texas Women, that you can get that screening done. It also did cover genetic testing, which I was not aware of. However, actually being treated by an oncologist and getting surgery, getting my chemotherapy, I actually found out about the Texas Medicaid for women with breast and cervical cancer through my community health worker course that I was taking at the time at my community college. So that wasn't something that was told to me by a medical professional or a resource navigator. So I was able to get ahead and get on top of trying to figure out how to get that coverage. And unfortunately, when I was calling trying to get that coverage, nobody from 211 knew what it was. And almost every single university health clinic that has the BCCS covering, nobody knew what it was. And I just had to keep going and scheduling appointments. And finally, I found one woman who knew one contact who was able to help me apply, because the Texas Medicaid for cancer is different. You can't apply for it directly yourself. You need a nurse or a social worker to enter in your diagnosis with their signature to help you apply. And while I was an intern at the Institute for Health Promotion Research, I actually did find a few other resources that are really great in the community that helps women pay for their oncology visits and chemotherapy. There are resources out there. It's just unfortunate how many medical providers and nurses are not aware of the information. So a lot of times, patients, other people I've met have really had to fight if they're low income or they don't have traditional health insurance. They really have to fight trying to figure out how to get coverage for themselves.
No, awesome. Those are great points. Thank you so much.
You're
Michelle,
welcome.
the Love Letter campaign, what did you find resonated most for the Latina community?
The imagery and the artwork definitely resonated in the communities. And actually, when we first launched the campaign, I had a woman who went around to a lot of the different communities here locally that took a lot of our artwork to actually activate her own communities. So sometimes it's the power of the community. And I want to double down on what Brittany was saying. Like, don't let your frustrations with healthcare stop you from asking questions. Don't let your frustrations and understanding of things you're being paid for keep digging. Keep a well-informed patient, and just as Dr. Monzo had mentioned, education and knowledge around this is your power. It's your power to get the answers that's going on in your body. Don't miss your screenings. And so the imagery really related and resonated with them because it's people that look like them. And often we learn that our Latina and our Black communities want to be seen by healthcare providers that are of the same and understand some of their risk factors as well. And it's just so important, the power of questions, the power of advocating for yourself, and helping one another. And I'm sure Brittany probably has passed on so much information to many cancer survivors or to people that are being diagnosed and being worked up, but don't miss your screenings. Ask your doctors about when you're ready for those screenings because they're meant there to help protect you.
Thank you so much. And now I'd like to go back to Marcella and Jessica. Both of you have mentioned a bit about the importance of clinical trials. So Marcella, maybe you can define for us what are clinical trials, the different types of clinical trials, and then Jessica, maybe you can talk about why it's important to see Latinos in clinical trials, or you can switch the questions, whichever you feel most.
So there is different types of clinical trials. For example, when it comes to the use of certain medications for the treatment of cancer, those clinical trials will go in phases. So you will hear phase 1, phase 2, phase 3, and that basically will be depending on the stage of development of the medication. So for example, phase 1 is when it's first tried in humans and we're trying to find the right dose for that, for that specific, indication. Phase 2 means that we're trying it out, a larger group of people. And phase 3 is when it's compared with a treatment that is already established as a standard of care. There are other types of clinical trials in which we, for example, do prevention. That I'll let Dr. Jones kind of talk about that because she's our expert in prevention and she's in charge of our care program. So I'll let her speak about that. And there are some clinical trials that, for example, can test certain symptoms or track symptoms to see that improves patient outcomes. So in general, clinical trials are our tool to move science forward. If you are a patient that it's being cared for and you're dealing with cancer, you will see that in academic centers, you will be offered participation in clinical trials for multiple reasons. For example, to donate a sample of your blood or just to answer questions. Sometimes we do also clinical trials to see if we can identify something in your bloodstream that will serve as what we call a biomarker that could let us identify certain side effects. But overall, these are, scientific projects that we develop with the purpose of improving the outcome of our cancer patients. And I let Dr. Jones kind of elaborate further too.
And
Well, go ahead, Dr. Ramirez. I apologize.
I just, maybe if you could also mention, why the word clinical trial? How did that, I don't know if we know how that came about, but sometimes just the trial aspect of it among our population is concerning, but also talk about then also the diversity and the need for diversity in trials.
Wonderful questions and wonderful points. Trial, are you experimenting with my life? I mean, that's the first thing that comes to mind. And the answer is no, we're not experimenting with your life. If anything, we're trying to enhance life. We're trying to move the needle. We think we found something better and we want a trial run of it. We want to do something about it. And it's in our clinics, in our clinical space. And so these words, clinical trial, I guess in some ways we're doing a scientific experiment, but it's not an experiment on your life. If anything, it's something that we have found that we think will make life better, that will make life longer. And we want to offer it to you as a patient. And it is important that these trials are held to certain standards. You don't want just anybody doing anything anywhere, which is to what Dr. Mazo was saying, is important that, especially in academic centers, we're held to a different standard. And, as an associate professor, I'm in charge also of not just trying, but we are educating the next generation of doctors. We are held at different standards. We have different responsibilities. And because of this, that is why we are leaders in terms of doing these studies. But we need everybody. We need Latina women. We need Latino men. There's a difference in the way that you can even see yourself if you've taken different blood pressure medicines or if you've taken different diabetes medicines. Our bodies are all just different, but we won't understand how different and how alike we all are unless we can try it on everyone. And so for that, I would say clinical trials are meant to make your life better. And so it is not a trial, it is a trial run to make it even better.
Thank you. And we have a question from the audience from Dr. Gomez. He's asking, do Latinos with European ancestry have a greater risk for breast cancer? Can ancestry be a future screening tool?
I think he's asking a very complex question, Dr. Gomez. By all means, I think there are some mutations that have been linked with people with European descent. A good example will be the Ashkenazi Jews and their high prevalence of BRCA mutations. So this specific portion of the population has a much higher risk compared to the general population to carry BRCA1 or 2, which are, as Brittany shared a moment ago, are genes that are linked with increased risk of breast cancer, among other cancers. I think this is an area of research. Latinos are so mixed. We come from so many places, and there's a lot of admixture in our ancestry that I think it's something that definitely requires more research to see if certain ancestry, and ancestry means basically identify in your genes kind of where you came from, what percentage of your genes come from North America, what percentage comes from South America, the Caribbean, European descent. So it's kind of seeing where you came from. And since Latinos, we come from different places, there's some Latinos that come from South America, some from the Caribbean, some are Latin Americans, and we all have different admixtures in our ancestry. So I think it's a good area that we need to do more research on. And hopefully down the road, we can develop risk assessment models depending on our ancestry.
Thank you very much. That was a complex question and more research that needs to be right. So, Michelle, we had a question also from the audience. Are mammograms and pap smear tests recommended in women over the age of 80?
I'm not a clinician, so I will turn that to Dr. Jones or Dr. Mazza to answer that question.
Well, I guess my question to you, Michelle, is if you were a traveling 80-year-old woman who frequently visited your family, would you want to get your screening mammogram? And I applaud that. That is how we should be looking at age. Is just a number. How active are we? How healthy are we? Our recommendations are made based on research that looks at overall survival, or essentially looking up to a certain age of 70. And so after the age of 70, what are these screening recommendations for? The question really should be, if I found cancer early in this woman, would I save her life? Would I change her life? And I look to my colleagues to answer this question as well. But I would say if there is a healthy woman, and if I were to miss breast cancer in her, would I take away her lifestyle? And if that answer is yes, then she's a woman I would offer screening to.
And that's who I'd be going to see, Dr. Jones is you.
And don't they say the 80s are the new 50s? So hey, we have a long life ahead, right? We need to keep moving forward. And you're as young as you feel. So great point, Jessica, that if you're healthy and, why not, keep up those screenings. So thank you so much. Another just kind of general question for whoever would like to answer this one is, we know that AI is really coming into play in a lot of different areas and being used in research. How are doctors incorporating AI into their practices?
I'm going to answer that question, and I will be interested to hear Dr. Jones' answer too. I think this is an area that is, that is coming along. There are some studies looking at AIs reading mammographies compared to, trained radiologists, with some studies showing that the AI actually is doing, a good job about reading those mammograms. By all means, I don't think artificial intelligence will replace a physician's judgment. That's my personal opinion. Have I used artificial intelligence? Yes, I have used it. For example, when we have a research question, certain AI platforms can help you kind of find quick answers and kind of elaborate more than certain, problems. But at least as of right now, which is, March of 2025, I don't see, and maybe I'm mistaken, and in 10 years we'll be having a different conversation, Dr. Ramirez, about this. But I think AI has some applicability, but I don't think it will replace the human, contact, the context of me talking to a patient. It might help me with my decision making as far as pulling data, but overall, AI cannot do the exam that I'm doing, cannot, talk to that person to see what symptoms they're feeling, and for me to formulate a treatment plan of what I think is best based on that interaction.
It's really
I don't know.
taking your knowledge and from all different aspects and your training to really make the best decision for that patient. Jessica?
If I could jump and follow up on what Dr. Mazzo has just shared, there will be no replacement for the human touch and for the human understanding. I I believe that, just as Dr. Gomez has left in the comment, clinical studies are needed to look at AI, and I believe as a supplement, maybe to some of our technology. I, for one, am excited about the use or the development of AI to assist with mammograms, to look for patterns of recognition. I am excited for this, but it still needs to be performed in a clinical study space so we can make sure that the science is sound, and that way you can trust what you're being offered.
Um, Also, I was just kind of, y'all have just shared so much. And for Brittany, what are you, I wanted to come back to your story. What are you doing now to kind of really, help prevent cancer from coming back? Because I know that for cancer survivors, that's the biggest worries. What kinds of things are you working on? What kinds of things do you share with your doctor? When do you transition to a primary care physician? And maybe some of you all might want to address that as well.
I have been focusing on my relationship with my oncologist, and I finished chemo at the end of June last year and had another surgery in September, which was just a revision, and started my Lynparza, the medical PARP inhibitor to prevent recurrence a couple months after that. So my body's gone through a lot of adjustments. I've been really listening to my body, and now I'm shifting more into changing the way that I eat and how physically active I am, because I do know that that also plays a significant role in not only preventing recurrence of the breast cancer, but it can also prevent developing another type of cancer later down the line. And chemo, there's like this stereotype that you're gonna be so weak and fragile and lose all this weight on chemo. But for me, it was the opposite. I gained a bunch of weight. I gained over 40 pounds because I was given a lot of steroids in combination with the chemo to prevent nausea and vomiting. And I didn't have an issue with eating. I actually had cravings and ate a lot. So now I'm working on getting my weight down, staying more physically active, And it's really good to take all the preventative measures that you can to prevent recurrence. I feel like I have a lot of reassurance, just feeling really confident that I have a very high chance of not experiencing recurrence because I chose to take my doctor's advice and get on the Lynparza, the PARP inhibitor.
Our moderator may be frozen,
I think she is.
but it looks to be 150. So potentially, maybe we could look here at the questions while our moderator regains her access. One of the questions was, oh, the mammogram screening greater than 80. Let's see. Oh, no, it doesn't look like we have any other questions. There was a question in the question and answer session asking about ovarian cancer. We don't have very good screening tests for ovarian cancer, but if there's a family history and we do identify genetic mutation, ovarian cancer is the perfect example of using surgeries to reduce a woman's risk. It's very hard to get ovarian cancer if you don't have your ovaries. And so, on that note, depending on a woman's genetic risk, we may remove or offer her these surgeries at different time points in her life. And there's other ways that we can support women if this is the case, knowing that your ovaries, they serve a huge purpose, especially the younger we are, to give us estrogen, which assists us in our bone health and our sexual health and our reproductive health. And so we want to make sure we preserve our general wellness, our well-being, our quality of life, while at the same time reducing the risk of cancer.
And I will add to that, Dr. Jones, this is why genetic testing is important too, as she pointed out. Ovarian cancer is not a very common cancer. However, we do know that patients that carry certain mutations might be at an increased risk. So they can proactively start their screenings. Let's say if the risk is high and they haven't had any children yet, right? There are young women in their 20s that is just not ready to have a prophylactic surgery. There's different techniques that we can use in partnership with our gynecologists and oncologists to be proactive and check that woman to make sure that they are not experiencing anything concerning when it comes to ovarian cancer. So having those discussions is also important. Let's see what else we have in our Q&A session here. Let's see.
I'd like to add something for the men that are watching when it comes to your family history, and just use my own genetic mutation as an example. BRCA, it increases the risk of breast cancer and ovarian cancer in women, but it also increases the risk of prostate cancer and pancreatic cancer in men. So even if you're a woman and you don't have a strong history of breast cancer, pay attention to the men in your family. If they have a certain pattern of developing a certain cancer, then that may be cause for you to want to get that genetic screening. And if you're a man noticing, hey, a lot of women in my family had breast cancer or they had ovarian cancer, you may want to go get genetic testing to see if you have an increased risk of predominantly male-related types of cancer.
That is a great point, especially because Hispanic men, especially Hispanic men, are very reluctant to pursue screening. And I've noticed too, when I talk to my patients in clinic, that when, let's say their sons need to be tested because they were found to have a mutation, they usually have a very hard time convincing their male sons to undergo genetic testing. So that's a great point, Brittany. Thank you so much. I think that there was another question in the chat. An anonymous attendee is asking about Lynch syndrome. Jess, do you want to elaborate on that one? So they're asking about what Lynch syndrome is and their increased risk of cancer with Lynch syndrome.
In our brief time left, as a physician that coordinates enhanced screening and enhanced surveillance scans, I frequently take care of patients that have Lynch syndrome. And very similar to what Brittany described, this is a genetic mutation. For a second, I just want to step back because there may be some of us on this call that may not know what even is DNA. And so for 20 seconds, I'd like you to imagine that you have a cookbook. You are born with a cookbook, and every cookbook has 2 chapters, and you have 23 chapters. And chapter 1 makes the brain, chapter 2 makes the heart. Think of it in this way. Now, the chapter that happens to deal with ovaries and the breast, somebody accidentally wrote salt instead of sugar. But you have a 50-50 chance of opening up your recipe book. It doesn't mean you're always going to make something with salt instead of sugar. It just means that it may happen. So on that note, Lynch syndrome is often diagnosed usually after a patient has been found to have perhaps a colorectal cancer. As the question and answer form is mentioning, increased risk of adenocarcinomas. So Lynch syndrome, these patients have a genetic mutation that predisposes them to developing colon cancers, but there's other cancers as well that we would monitor for because this is not the only organ that's being controlled. So in this case, we would also look for, we usually scan the whole body because of the risk of different types of tumors. I wish we had more time to go into that question, but in any case, I think my biggest takeaway is having a genetic mutation doesn't mean you will always get something. We're hearing today from Brittany because it did happen. But if we do know that there is a possibility, let's do things differently. Let's change the narrative. Let's make you a victor and not a victim.
Awesome. And thank you. I'm sorry about my glitch with Zoom, but I'm glad to be back. And most of all, I just really want to thank each and every one of you. You brought so much wealth of information to share with our audience, and the questions were great. So audience, thank you for your active participation in today's webinar. So thank you again for your amazing work, and let's continue to promote cancer prevention and screening. And we need to do another session on just male cancers because we know that they're some of the most stubborn individuals to come in for screening, but we want them here. We want them for a long time. So again, thank you all for your amazing stories. And I also just wanted to share some important resources that our audience may want to know about. One, at UT Health San Antonio, we can help you make a cancer screening appointment. We have a website that you can go to. If you don't have your own primary care physician that you'd like to come in for screening, please let us know. We're here to help you. Outside of San Antonio, the American Cancer Society has a great website that you can enter your location and find a screening location near you. It's called getscreen.cancer.org. And then also, we'd like to promote our clinical trial resources and testimonies that have been done as part of Salud America. We need you. We need your participation in clinical trials. We have our own ongoing cancer survivorship study called Caminos that we'd love to see you participate. If you're a Latino who've experienced cancer within the last 10 years, we need you. And then we will be adding this webinar with its just wealth of information to our YouTube collection, and we'll be sharing a link with everyone who was on in the audience today so that you can share that with others. So it will live on. And again, we want to give a special thanks to Michelle, our Genentech sponsors, for allowing this webinar to be able to take place. So thank you all. Have a wonderful day and come back to our next session that will be coming up soon. All right. Thank you all. Take care. Have a great day. Bye-bye.
Thank you.